Good evening to all the aspirants present here. Some more aspirants will be joining us soon. The topic for today is endocrine disorder, class 2, and the speaker that we have here is Dr. Avishek Roy, who is an associate consultant ICU in Apollo Multispeciality Hospital, Kolkata. And I would like to ask the aspirants to kindly mute your mic. Any uh, any question or queries, please ask in the comment box. In the chat box, you may drop it there. In the Q&A session, we'll be answering those. Thank you. So you may start.
So good evening, everyone. I'll be starting the second part of this endocrinology part. So previous class was on sugar control and the diabetes and the diabetic emergencies, and this is on the rest of the important parts pertinent for our ICU care. So the common disorders, the first portion that I'm going to discuss is adrenal glands and steroid hormones and their usage and the important areas to focus. So common disorders that will come up ICU regarding adrenocortical function are these listed here. So we can have a Cohen syndrome, which is primary hyperaldosteronism, while the aldosterone level goes up and causes few derangements. We'll come to that later. It could be secondary hyperaldosteronism, which is seen in patients who have hypertension, underlying heart failure, or chronic liver disease, where there is a secondary cause which leads to an increase in the aldosterone level. You can have hypercortisolism, where you have Cushing syndrome, characterized by an array of clinical features, which I'll be discussing, and Addison's disease. That's a primary cortisol deficiency from either the pituitary or the gland itself, and the clinical features again are varied. So I'll come first to the discussion on the adrenal insufficiency itself. So adrenal gland secretes mostly three types of hormones. So the layer wise from outside to inside, it has got the cortex and the medulla. The cortex is divided in three parts. We can remember is that GFR. GFR stands for glomerular filtration rate. Similarly, we can remember GFR. So it's zona glomerulosa, zona fasciculata, and zona reticularis. Zona glomerulosa secretes mineralocorticoids. The main or important one of them is the aldosterone. Fasciculata secretes glucocorticoids. Just remember the G is not for G. So glomerulosa secretes mineralocorticoids, fasciculata secretes glucocorticoids, and reticularis secretes sex steroids, the androgens, the testosterones and the estrogens. And the medulla has got a separate function of its own, namely the endocrinal part and everything that is there. It secretes the epinephrine, the norepinephrine, and all. So it's situated, the adrenal gland is situated anatomically over and above the kidneys. The right and the left has a bit peculiar distribution, but it's suprarenal in their distribution. It has got a separate fascia on its own, and the blood supply is directly from the aorta and some from the the kidney branches. Uh, so the nephric branches gives it a blood supply. Now that's the gland related part. What is the supragland control that we have from the brain? So we have the hypothalamus, which secretes something known as a CRH. This is pertinent for our cortisol. So CRH is cortisol releasing hormone. So hypothalamus, situated around the third ventricle, secretes CRH, which activates the pituitary at the pituitary fossa, activates the pituitary gland. More importantly, the anterior stalk or the anterior part of the pituitary, and it secretes the ACTH. ACTH is adrenocorticotrophic hormone, which comes and has trophic effect on the adrenal gland, which helps to secrete all this hormone. And whereas this via the mechanism of negative feedback, these hormones inhibit the release of both CRS and ACTH, and that's how the tightly regulated these are. So this everything, the secretion of cortisol is dependent on the circadian rhythm as well as stress. It does not have a constant plateau or a constant level of secretion throughout the day. It fluctuates a lot, and that's why we have a specific timing for drawing blood samples when we suspect Addison's. So cortisol is a hormone which is a steroid hormone. It's 90% bound to cortisol binding globulin, some of which belong to pre-albumin and some of which are bound to albumin. T half is around 70 to 120 minutes, and the cortisol acts by the intracellular receptors. Normal level in healthy patients are 5 to 24 microgram per deciliters. So physiological effects, mostly it's metabolic effects. Then we have cardiovascular effects, and these are the major two. So metabolically, they increase blood sugar levels by stimulating gluconeogenesis. They reduce the glucose utilization in the tissues, thereby again increasing the sugar levels. They reduce protein synthesis and promote catabolism. That's why it promotes the muscle mass loss if given in excessive amounts. And it also causes lipolysis. So free fatty acids are also increased in the serum, causing a kind of a acidic milieu on its own. Cardiovascular system, it increases the heart rate, increases the blood pressure. It has got a permissive action. It does not have a direct action, but it kind of helps the adrenal glands medulla to take part, and the epinephrine and the norepinephrine take action and thereby increase the blood pressure and the heart rate. It also has a permissive action on the angiotensin, and thereby hydrocort or cortisol helps to retain fluids and sodium. So these are the main properties of it physiologically. Now, most importantly in ICU, or other important properties, anti-inflammatory property. So cortisol or any steroids per se reduces the phospholipase A2 mediated activation of the inflammatory pathways. So it downstream from the phospholipase A2, we have got the arrays of eicosanoids, and the different mediators of inflammation like the prostacyclins, which get secreted. It inhibits the inflammatory reaction. It also suppresses T and B cell reaction, reduces the eosinophil in the blood, and therefore T, B cell, and eosinophils, neutrophils, these are all main, especially the eosinophils, these are all main macrophage produce or helping cells or macrophage type of cells, and therefore the reduced macrophage activity is also seen. The primary causes of adrenal insufficiency could be a pituitary cause or could be a gland cause. When it's a pituitary cause, so the pituitary cause could be anything like a tumor, a trauma, infection, infarction, inflammation. So if you got a tumor infiltration into the pituitary, if you got a trauma of the pituitary, or you have an infarction that affects the pituitary, infiltration in the form of sarcoidosis or hemochromatosis, you can have this. Similarly, if you have a gland which is affected by autoimmune disorders like polyglandular syndrome or primary Addison's with an autoimmune feature which affects the gland, it can have you can have adrenal insufficiency. Congenital adrenal hyperplasia, it's not so important in adults, but you can have it in children, which is one of the common cause of adrenal insufficiency in them. This is one of the flowcharts of steroidogenesis. So steroids again essentially are prepared from cholesterol by the enzyme cholesterol desmolase, and then it has got, it bifurcates to two different pathways. One gives rise to three different pathways. One gives rise to cortisol, one gives rise to the aldosterone, which is the mineralocorticoid, and one to the sex steroids, depending upon the different enzymes. And the congenital adrenal hyperplasia is a situation where all of these different enzymes are deranged in different manners. It is not a topic of discussion for today, but this pathway is important in that case. So other than that, in adult patients coming with primary Addison's, we have to always rule out an infection of the adrenal gland. So the most common infection of the adrenal gland are tuberculosis, histoplasmosis, cryptococcosis, primary HIV infection, and cytomegalovirus infection. I'll again repeat: tuberculosis, histoplasmosis, cytomegalovirus, HIV infection, and occasionally you can have a metastasis. For example, you have some abdominal tumor previously or a pancreatic malignancy, which an adjacent spread to the adrenals coming with hypotension. And it can happen that metastasis has weakened the adrenal glands functioning. So some of the drugs which are again used for patients with Cushing syndrome, but itself can cause adrenal insufficiency. So the CYP3/4 mediated, the enzymes which mediates are metabolized by the CYP3/4 enzyme. The inducers of them increases the metabolism of steroids and thereby promoting an adrenal insufficiency states like rifampicin, carbamazepine, etc. Directly does not cause adrenal insufficiency. However, few drugs like mifepristone and then chronic steroid use itself, because chronic steroid use reduces the hypothalamus pituitary axis functionality and reduces the steroid hormone action. And megestrol also is a similar kind of drug which reduces the HP axis activation. And also the steroid synthesis can be inhibited by different mechanisms like the inhibition of the 17 alpha hydroxylase enzyme, all the cholesterol desmolase enzyme, among whom these are the main important drugs: the metirapone, ketoconazole, and etomidate. Ketoconazole is one of them which is very readily available. It has got its own toxicity and side effect. Other than that, oral ketoconazole is commonly used when you suspect hypercortisolism. So we are discussing now adrenal insufficiency. So the ketoconazole can lead to adrenal insufficiency if used in other scenarios. Now, very rarely it can be due to hemorrhage in the adrenal glands, as we have discussed. So the most common symptoms in an ICU patient, moreover, would be hypotension, along with that some dyselectrolytemia in the form of hyponatremia and hyperkalemia, and we can have normal anemia acidosis. So the symptoms like fatigue, which are common in ward patients or OPD patients, or loss of appetite, and in cases where there is a cause is not the pituitary, that means the cause is adrenal glands, we have hyperpigmentation, because the areas, the promoter gene sequences which it helps to release ACTH lies very close to the melanin secreting areas, and thereby whenever there is a reduction in the levels of steroids, the ACTH level goes up. Parallel with ACTH, the melanin level goes up. So skin hyperpigmentation and postural hypotension, which is seen in adrenal cause, it is not seen in secondary hypoadrenalism or cortisolism like a pituitary cause. But very important to remember, you should always suspect in an ICU patient if you get these features: low blood sugars, hypotension, anemia, unexplained fever. Probably I missed out on mentioning this. Unexplained fever, it is one of the cause of a pyrexia, non-infective cause of fever in ICU. Adrenal crisis per se can be precipitated by an infection, trauma, surgery, stress, anything. What labs you can send? You can simply send a random serum cortisol and ACTH just to have an idea about how the axis is functioning. So if you got cortisol which is low and ACTH which is high, it means the gland is at fault. So your gland, if it is at fault, this cortisol is low in all of them. But cortisol low, ACTH is high, means the pituitary is normal. So it is the gland which is the dysfunctional. Whereas if your cortisol and ACTH both are reduced, it is usually the pituitary. However, in an ICU patient, the level of ACTH can also vary significantly, and therefore, only based on a cortisol and ACTH, that to in an ICU patient can sometimes be tricky. So do not go only by the blanket statement that I have discussed, and many things, particularly in ICU patients, are not well defined, or the values are not well described. So just remember it for usual for clarity purpose, but this ACTH test does not always hold true. Other than that, whenever we suspect that okay, the adrenals are not functioning well, you do a basic screening ultrasound, and followed by you do an MR of the adrenal glands to look at the anatomy. You may have to go for a biopsy to prove a adrenal histoplasmosis or a tuberculosis. Now comes the screening test. These are mostly important for a non-ICU setup, but for diagnosing up entity, which I'll be discussing later, the CERC. In those cases, ACTH stimulation test is very important. Now there are two types of ACTH stimulation test. So what is ACTH stimulation test? Physiologically saying, when you give ACTH, your cortisol level should rise. Simple as that. Now, if your ACTH, despite giving ACTH, cortisol does not rise by a certain amount, that means there is a dysfunctional HPA axis. So the first thing is to remember there is something known as a low dose ACTH test, where you give a 1 mg dose, and before and after that you check the cortisol level, and if the rise is less than 9 microgram per TL, it is diagnostic of an adrenal insufficiency. There is also, for diagnostic purpose, we can use a high dose adrenal ACTH stimulation test. The difference between the two is that when you suspect an adrenal insufficiency, and you want to be sure about it, physiologically saying, you should be using a low dose, because if there is a suboptimal function, not that the adrenal glands are completely depleted, but probably if not functioning well, you want a low ACTH test so that you can find out all the cases suspected to have adrenal insufficiency. If you give a high dose ACTH, probably the ones which are functioning less will function more in that scenario and give you a false positive result. However, the clinical trials have failed to show a difference between the two in terms of low versus high ACTH. And since low ACTH is very difficult to give as a bolus, so practically saying a high dose ACTH is what is preferred. So If you have any doubts regarding this concept, you can ask me after the class. So high dose ACTH, which is 250 micrograms of that is 0.25 milligrams of cosintropin, which is given, and then afterwards you draw samples at 30 and 60 minutes, and infer based on the difference. Management of insufficiency of hydrogen insufficiency is simply giving steroids. So you give steroids, you adequately resuscitate the patients with giving adequate fluids, and you need to be looking out for patients who are candidates for developing adrenal insufficiency, especially the ones who are on chronic steroid use. The definition of chronic steroid use is different in different textbooks. Many areas they mention as 5 mg per day for more than 4 weeks, at least within last 3 months. Some say 10 mg per day for at least 2 weeks within the last 3 months. But the main motto that we have to remember is that you 5 to 10 mg per day for at least 2 weeks within last 3 months. That's the definition of patient who is dependent on steroids. And the take home point is that even if this patient is not currently on steroids but has received steroids in the recent past, if they're undergoing any procedure like surgery or some kind of other intervention, it is always advisable to give some stress dose steroids during that part, during the surgery, or the especially at the beginning. This is one important chart. So this is again mentioned in the later chart. So the relative comparison of all the steroids. Now this I want to everyone to look here and concentrate, because I don't know whether questions can be asked from this, but definitely it is a very handy tool you can use in regular day-to-day practice. So what we can remember is that relative potency wise, if you consider that your glucocorticoid potency is 1 and the baseline molecule that you remember is hydrocortisone, so your hydrocortisone or cortisol is having that's a basic parameter or the basic molecule which has a glucocorticoid potency of 1. So just remember this. 5 times of that is methylprednisolone. So 1 mg hydrocortisone equal to 5 mg of methylprednisolone equal to 4 mg of prednisolone. 4 mg of prednisolone. So methylprednisolone is more potent as compared to prednisolone. So what we use, methylpred, is much more potent as compared to betamethasone, which is 25. Relative glucocorticoid potency is 25, but the dose wise is less. Dose wise it's 0.75. If I'm not, let's just cross check once. Yeah, so the betamethasone equivalent dose 0.75 is hydrocortisone 20. So I'll break it down based on the glucocorticoid potency wise. So hydrocortisone glucocorticoid potency is 1, methylprednisolone glucocorticoid potency is 5, betamethasone glucocorticoid potency is higher, 25, dexamethasone again equal to that, fludrocortisone again lower, 10. Now come to the glucocorticoid is to mineralocorticoid potency. Hydrocort, it is 1:1. For prednisolone, methylprednisolone, which has a higher glucocorticoid action, 4 or 4 to 5 is to 0.25. So it's almost 20 times higher glucocorticoid action potential action. Betamethasone, dexamethasone does not have any mineralocorticoid action. Fludrocortisone has predominantly mineralocorticoid action. Aldosterone, pure mineralocorticoid. So this is based upon the glucocorticoid and the mineralocorticoid potency. Coming to the dose wise or the dose wise potency wise, hydrocort 20 is equivalent to methylprednisolone 4 is equivalent to prednisolone 5 and equal to dexamethasone and betamethasone of 0.75. So this you have to remember, that if you are giving a 100 mg hydrocortisone to a patient and if you are asked to convert it to methylprednisolone or vice versa, so 100 mg hydrocort would be equal to 4 into 5, that's 20 milligrams of methylprednisolone per dose. Okay. Similarly, if you are giving 40 mg methylprednisolone, that is equivalent to giving 200 mg of hydrocortisone per day. So this is dose-wise potency, anti-inflammatory potency, as I've discussed, based on the mineralocorticoid and glucocorticoid action. Now, one thing is to just another concept that I'm putting forward is that when you want to curtail or reduce the inflammation in your body or use the steroid as an anti-inflammatory markers or anti-inflammatory agent, for example, acute respiratory distress syndrome or fulminant flare of any autoimmune disease, you want to use something which has an anti-glucocortic or rather glucocorticoid action or anti-inflammatory action. So use methylprednisolone or prednisolone over hydrocort. However, if you want to use something which is short acting and it has got blood pressure wise or it has got hemodynamic effects, for example septic shock patients, then we always prefer hydrocortisone, because methylpred and dexamethasone, they don't have the mineralocorticoid action. They won't help you with stabilizing blood pressure. So there you prefer something which has a higher mineralocorticoid action. So this is one important thing to consider. So when you are giving it for only ARDS purpose, use Dex or methylpred. When you are using for septic shock, give a hydrocortisone. Now, coming to again back to the study protocol that we use for ACTH stimulation. So there is a short 8 hour and 2 days infusion. These are again based on OPD data and all. What we standard follow standard guidelines say use a 250 micrograms of dose of ACTH. This is again based on your ward data and the OPD patients, how you suspect and then how you work up. For us, it's mostly to remember that what is the high ACTH stimulation test, and high ACTH and low adrenal glands indicate that the gland is at fault. So you act accordingly. If low ACTH, low adrenal, low cortisol, it's a pituitary which is mostly at fault, and you investigate accordingly. And then based on the underlying etiologies, you go and work up. Till that point, you supplement with steroids and you manage the electrolytes and the acid base balance. That's the entire point about managing these patients. And what I told previously about the chronic steroid abuse, steroid use patients, that how to manage them, just remember one rule, that when it is a minor surgery, for example, a patient who is dependent on steroids, the definition I've already discussed, you want to give them a hydrocort, give a 25 to 50 mg stat dose if they're undergoing a minor procedure like small incision surgery, some skin surgery, superficial surgeries, cataract surgeries, etc. But if they're undergoing major to intermediate surgery, give a low dose prophylactic cover, just like 25 to 50 mg BD to TDS, that's around 75 to 100 mg per day of hydrocortisone over 40 to 72 hours. So you start during the preoperative period, throughout the OT you have to give, and afterwards, generally post-operative day or two, 1 or 2, you can taper it off. Now this is outside of critical care purview, but you have to remember because many patients are shifted who have taken steroids for a longer time. They have come to your ICU. If you switch off the steroid just like that, they will end up in high Addison's crisis and they will have coma. Now, this is the most important entity that you want to be knowing about, that is CIRSE. CIRSE stands for critical illness related corticosteroid insufficiency. So what happens is critical in patients is there is a dysfunctional or insufficient functioning of the hypothalamo-pituitary axis. The major reason being your stress or the infection. So stress or infection, it tries to promote a cytokine inflammatory response, which in turn blocks the HP axis. It also reduces the hypothalamic activation and thereby the CRH stimulation of the pituitary, and it itself has an intracellular effect by which it reduces the steroid binding to different and inflammatory molecules and thereby promoting inflammation and reducing the steroid effects. Moreover, what it does, it blunts the steroid response. Supposedly, there has to be X number amount of response to a steroid dose or body's response to a steroid. In infection and inflammation, it mounts to X by 2 amount, whereas it should be mounting to X amount. So there is a reduction in the amount of response. It also causes a peripheral glucocorticoid resistance. So these are all the different mechanisms or thought of mechanisms. So increased cortisol or decreased levels of cortisol binding globulin, which is the major molecule where it binds, and also the glucocorticoid resistance, which are causes of this phenomena. So when you suspect it, you can send labs just like we have discussed about Addison's. We send the serum cortisol levels, we send the ACTH levels, but first and foremost, the normal cortisol, which is normally 5 to 24 microgram per deciliters, does not hold true here because your you don't know the exact level of steroids that or hydrocort that should be cortisol should be present in your blood when you are undergoing a stress. So normally it is higher. So instead, supposedly in an ICU patient, it should be around in the range of 50 to 60, which is higher than normal. But still, if the needed response is less than what it should be, it can be called as CIRSE. So it's a relative phenomenon. It's not an absolute. It's a relative lack of the adrenal glands to mount a steroid producing response with respect to stress. How to diagnose? This is the most important concept. The best diagnosis point is that if you have a cortisol level rise after an ACTH stimulation test less than 9 microgram per deciliters with a baseline of less than 20. If you remove this portion with a baseline, can it be diagnosed as CIRSE? Answer is yes. If your baseline is still above 20, but you suspect that the patient is having CIRSE and you're mounting the ACTH stimulation test shows a delta change, that is before and after ACTH change of less than 9, that can be also marked as CIRSE. a single value of less than 5 also mostly point towards that possibility of SARC. Now, again, these are not, say, dogmatic or definite criteria or definition of the SARC. I have found out the internet that there is no, as per the guidelines also, it tells about the pathophysiology but does not tell about the exact definition. So it is a dynamic phenomenon. And again, as I said, there are a lot of confounding factors which there is are at play while diagnosing.